everyone. Rethinking Social
Konferansı'nın
Services. Welcome to this session of this conference. This is the last session of the first day. The third and last. We have 4 speakers in this session. Let me first give you the names of our speakers, and then I'll give the floor to them. Our first speaker is Professor Dr. Nabile El-Bassel. She works in Columbia University in the state of New York, and she's a professor in the Social Services, School of Social Services. Our second speaker is Professor Dr. Suzanne Spindler. She's from the School of Applied Sciences in Düsseldorf, and she's a member of faculty in social work. Our third speaker again is from Germany, from Berlin Protestant School, Professor Dr. Gülyane Karakayala, namely. And our fourth speaker is from social society and activism pillar, representing that aspect on this panel. And he's from the Kırkayak Cultural Center in the southeastern province of Gaziantep in Turkey, Mr. Kemal Vural Tarlan. So today, our first speaker comes from the state of New York, and her study is on opioid, the contagion of opioid use. That's her main theme. So Dr. Bassel, the floor is yours, and thank you. Microphone, please.
Shall I use my slide?
Yes, please.
Okay. Can I get started?
Yes, please.
Thank you very much for the opportunity to participate in this important conference. I really appreciate the invitation. The title of my presentation is Community Engagement Intervention to Address the Opioid Crisis During COVID-19 Pandemic in the US. In the coming 20 minutes, I'll talk about goals of the Healing Community Study. It's a community-based intervention research that address both COVID pandemic as well as the overdose epidemic in the United States. I want to focus a little bit about the conceptual model that guided the study and give you examples of the type of interventions we're using and how we tailored our intervention to look at the impact of COVID-19 in the past several months. And I will end by some concluding remarks. I want to start by telling you why it's important to focus on the drug overdose in the United States. I want to mention that from 1999 to 2019, more than 500,000 people died from drug overdose in the United States. And in 1 year, in 2019, 72,000 people died from drug overdose. And in fact, drug overdose fatalities remain higher than deaths from car accidents, shootings, and AIDS combined. And after COVID, especially between January and April in 38 states, we see that there is increase of 18% on non-fatal overdose and 11% on increase on fatal overdose. I'd like also to mention that this requires a lot of investment in addressing the pandemic of COVID as well as the overdose pandemic, because they're really a pandemic, and within this pandemic, there is an epidemic. Something is... So the Healing Community Study is funded by the National Institute of Health, and it's the largest study on community-based research. It costs $350 million. And this study is delivered now in 4 highly impacted communities by the overdose death. And the purpose of the study is really a very ambitious one. The plan is to reduce opioid overdose death by 40% over 3 years within 67 highly affected communities in 4 states. And when I say highly affected communities, these are communities that are heavily impacted by overdose deaths. In this for a 67 community, there are 10 million people live in these communities. And if we look at the death rate in this community because of overdose, it's ranged between 27 to 40 per 100,000. And when we designed this study, we included half of the communities to be rural communities and half are urban communities. Because this is a study, clearly that we have to use a design, and the design, it's multi-site, and we call it parallel arm cluster randomized waitlist control trial. It means that we randomize the 67 counties in 2 arms. One arm received an intervention immediately, and the waitlist control arm, half of the communities would receive the intervention 2 years post randomization. So I want to make sure that give you a sense of the conceptual model that guided our thinking and the study itself. The healing community study is defined as an advanced stage of community engagement hierarchy. The study is community-owned, community-driven, and managed through a coalition. In every county we work with, we created a coalition. The coalition is asked to use data-driven solutions to address the opioid epidemic. And when COVID came into the picture several months ago, we also integrated the issue of COVID within this pandemic. So we created a coalition within each county. Each coalition consists of 25 to 40 members, and the members are policymakers, health and substance abuse providers, people with lived experience, family who lost their family members through the overdose, and we included governmental officials. In each coalitions, we also identified champions. Champions can be people with lived experience or could be policymakers who take care of how to deliver evidence-based solutions to the opioid epidemic through the coalition. It's very important to highlight, in order to succeed in this community-based research, the role of local government, the health and mental health commissioners, and politicians and policymakers are part of the coalitions. One piece I want to really highlight in this approach that we've taken in the healing community study is deploying data-driven evidence-based practices, all the practices that we deliver into the community to reduce overdose death in 40% 3 years have to be data-driven, have to be evidence-based. We work with hospital, jails, prisons, drug treatment, recovery center, and more settings. As you all know, that the community intervention is, and especially our community that heal approach, is guided by community-based participatory research, which means that the full participation of the community in all the stages of the research, in the design, implementation, and evaluation, and also there is equal partnership between the researchers and the community that work in the coalition. It's also about inclusiveness, meaning that in our coalitions, we included underrepresented, disadvantaged, vulnerable, and marginalized groups, and people with lived experience, because their voices are very important. Clearly, when we include a vulnerable population within the coalition in such study, we have to include the safety of the people. We have to make sure that the people who are in the group and have a lived experience with drug use, their voices are heard, but also they're safe. Also, the principle of the community-based participatory research emphasize local context. It's really important that the solution that the coalitions come up with need to take into consideration the conditions and local capacity of the community. It's about sharing power between the research and the community. We foster co-learning, co-designing, and the plan of the solutions between the researchers and the coalitions. We share benefit, meaning that we create a balance between generating knowledge for the research, but also for the community needs. Data-driven implementation, this approach that we are implementing is about data-driven. Every piece that the coalitions engaged in delivering evidence-based practices have to have data to support their approach. Is about sustainability. The solution that we create through the coalitions, where the coalitions and the researcher work together, is about how we sustain this after the research is over. And the final point about the principles of community-based participatory research is about cultural humility. Researchers are required to use cultural humility and understand very well the cultural context of the communities. I also want to mention that we use a conceptual model called the PRISM to help us to assess the process of the implementation of the research. The PRISM conceptual model guided us to understand what external and internal factors we are going to assess and use to see the barriers of the implementation as well as the facilitators of the implementation. I also want to mention that this model that we created, it's called a phase model, where we tell the coalitions that we are going to move from phase 0 to phase 6. And let me briefly explain to you what I mean by phase 0. Phase 0 is about we creating the coalition, the researcher working with the community, working with the health and mental health and local government to create the coalitions. And second, the phase is get started. Get started where we define and understand the mission of the coalition and define the champions. In phase 2, we identify community priorities and the evidence-based practices that need to be used to solve the overdose crisis. And with COVID, we approach the same process. And in phase 4, we start with the community action here, where the coalition start implementing evidence-based practices to solve the overdose crisis during COVID and before COVID. And here in phase 5, we start really about implementing the solution and measuring the progress and the implementation of the model. Through all this process, we also assess the fidelity of the implementation of the coalition process and implementation. And phase 6 is an important one because it's about sustainability. When we finish with the study, we want the model to stay and we want the capacity to be in place. But also I want to mention, although we get the coalitions to decide what evidence-based practices they need based on science, we also tell the coalitions they need to use 4 important evidence-based practices. First one is expanding overdose education and distribution of naloxone. I'm not sure if you are familiar with naloxone. Naloxone is a medication that reverse overdose. If someone took drugs and overdose from the drugs, this medication, naloxone, can be given injectably or orally, and they can reverse the overdose. The person can survive. Through COVID, that was very important to make sure people who use drugs and their families access naloxone. This is an important and very effective treatment that can help people to survive when they're taking drugs. We also tell the coalition they need to access medication for opioid use disorder. These are evidence-based practices, interventions that can be used to help people to using drugs safely, or also to use a medication and can survive while they're using drugs. And also we know that safe opioid prescribing for acute pain across all the healthcare system in the United States is a problematic. And we tell the coalitions that they need to use to help the community to use the guidelines that are very important about educating the health providers to use safe opioid prescribing. And the final point, which is really an important really component that we tell the coalition to use, especially during COVID, is to reduce a stigma against naloxone use, against people who use drugs and those who receive drugs, because there is a huge stigma. And especially during COVID, this stigma amplified. People who use drugs became really isolated, and we wanted to reduce stigma to make sure before COVID, during COVID, after COVID, we needed to reduce stigma around the medication they use, and also around recovery, because people even in recovery, there are also stigmatized. So during COVID, we switched our work to focus on two important area is about really fast tracking naloxone to reduce overdose deaths. We wanted to get naloxone, the medication that can help people to save lives, everywhere to be integrated. We also wanted to focus on stigma reduction, on communication campaigns to make sure that people who use drugs and at risk for COVID not to be stigmatized. So let me give you an example of how we, as researchers working with the coalition, we were able to fast track naloxone, meaning make sure naloxone gets to everywhere, to all people that they need them. So the coalition in each county decided to do a landscape where they need to go to find people during COVID who need who use drugs but also at risk to overdose and die. So we decided to go, and many of the coalition did go to a home of people, to their family members, to jail, prison, homeless shelters, to soup kitchen. They went to supermarket, to gas stations, went to pharmacies, and went even they mail naloxone to make sure that people who need them can survive, because during COVID we heard people are dying from overdose from drugs at home and have no access to naloxone. So we distributed in a huge number of naloxone in everywhere to save lives. The other piece that we decided to do during COVID is, as I said earlier, is reduce stigma against naloxone, against medication for opioid use disorder. And we encourage family members to really make sure that they're around for people who use drugs. So what our slogan has been in our stigma reduction, opioid use disorder is medical disease. People with opioid use disorder deserve the best medical treatment. So we wanted to make sure that these messages get into the community. We targeted people with lived experience and their loved ones, their families. We targeted key opinion leaders. We targeted healthcare and other providers. We targeted the community. We went to the street and make sure that people who use drugs are not stigmatized. Here, a model of where we put our stigma messages. And
Excuse me, Nabila. Just want to say that you're past 15 minutes. Sorry for interrupting.
okay, yeah, I'm finishing. And here is an example of where we put the ads. Here, doctors are talking to the community, first responders and family members talking about how we need to reach out to drug users and reduce stigma. This is another campaign we put everywhere on the street, on buses and cafe places to really tell people where to go and to get services, but also to reduce stigma. So in conclusion, I want to say that this model, the Healing Community Study, is about saving lives of people that might otherwise die from an opioid overdose. Also, it's about advancing scientifically an approach of community-based research dealing with an epidemic like overdose epidemic within a pandemic like COVID-19. It's about advancing community-based research. And also we used the structure we built to deal with the overdose death crisis to address the same approach dealing with COVID. And we continue to combine addressing COVID with addressing overdose deaths. I want to end my presentation by saying, yes, the School of Social Work at Columbia University is leading this study. However, this work cannot be done with one discipline, one investigators. Here, only at a New York site, we brought around 60 scientists from social work, from public health, from addiction medicine, from modeling, from system scientists. We work together to address these issues, and we continue to work together across the board from 4 states. We have 300 scientists are working together, and we believe community-based research requires a multidisciplinary thinking, multidisciplinary science, and also a collective efforts that all the scientists work together to address both the opioid crisis and now the COVID pandemic. And thank you.
Um, Thank you very much, Nabila. This was just a wonderful, really eye-opening uh, presentation. Pardon, Türkçe konuşayım. Bu gerçekten çok ufuk
This
açıcı.
has been a very interesting, mind-shifting presentation. And especially at the end of the previous panel, one of the speakers, Jane McPherson, mentioned that the social workers can always employ alternative modes of work. And we had already started discussing that. And specifically, this is a study that involves and engages the community. And I believe that it was very important. Thank you on behalf of everyone. Now that I remember them, I also would like to thank the interpreters a lot, because sometimes I forget to thank them before I close. During the morning panels, they made a great job, and I would like to thank them. Now I'd like to give the floor to the second speaker. Second speaker is Professor Suzanne Spindler. Her title is Migration and the Pandemic, Social Work within the Context of Increasing Inequality and Exclusion in Germany. You have the floor, madam. Thank you.
Thank you so much. Yeah, thanks to all the organizers and translators. And yeah, it's such a pity that we can't be together in real, in person, especially greetings to people I know, to Tekin, to Yasemin, Neshe, and Dennis. And yeah, thank you for organizing this great event. Yes, I try to share my screen with you and hope it will work. Yeah, I think you should see now the presentation on migration and the pandemic. Thinking on social inequality and vulnerability, which as well as the title of this panel, it's not that the virus doesn't make no difference between people. We know that rather people are, depending on their life circumstances, in very different ways vulnerable and attackable. It's not only the strength of everybody's body with their own history, but it's as well a question of resources to protect one's life and as well lives of the others. So the chances to do this are very unequal distributed, and we can ask some questions on that, like who has access to money, to own dwellings, to places of physical or psychological health care, to safe spaces, who has access to information, to possibilities, to social distancing, access to media, to social media, to live your life relations, although there are physical limits, and who has access to the basic rights like food and water and options for the future. So in my presentation, I would like to concentrate on the situation on refugees in Germany, and we can see very clearly in lots of or in many parts of life of not all but many refugees, the effects of the pandemic within the migration regime and as well on social work. So the situation within the lockdown was affected, the situation of refugees within the lockdown was affected by very few resources and a dramatically rising vulnerable situation. The interference with the migration policies getting more and more restrictive. We're going to talk about that. I think Juliane will go on with this theme in the next presentation as well. So hopefully it combines the two presentations. I would like to concentrate on the distribution of thinking on the distribution on resources and the demands on social work, on the situation of vulnerability and the limitation of resources under pandemic. So what do we see when we have a look at the situation of refugees? What impacts does their situation under pandemic have on rights? And which role can we see for social work in Germany in this very excluded part of society? As Serhat Karakayali and Vasilis Tsianos analyzed already in 2005 the central function of the migration regimes by structural racism and exclusion that goes along with the deprivation of rights. So I would like to take a special look of what happens to the rights within this situation. So first of all, we had today we had already the presentation of Rory Toole about of the International Federation on Social Work, about the challenges on social work, and I want to figure out which demands on social work we can see when we just take the definition on what social work means of the International Federation and which demands result on that. So everybody can read this small definition on social work. That's on the left hand. If we look on the demands that following this definition, we see that one demand is to support refugees in social participation with equal rights, to support them in living a self-determined life, to help them to accomplish their rights, and to figure out and fight against barriers foiling participation and people's rights. And we have to take a look at what happens to human rights and or social work as a human rights profession as well, and principles of social justice that are the base of the work. So I will gonna have a look to the limitation of those basic rights as mechanisms of institutional racism, and would like to ask the question: which limitations do we find, and how do they lead to limit basic rights? When we first have a look at the situation in refugees camp, there's not, I mean, those pictures are from before the pandemic. So on the first view, there might be not that much difference on the situation, but we can see that Corona changed a lot for the refugees and as well for social work within the camps. So first of all, non-refugee citizens and refugees got in a paradox situation with Corona, while the whole population was urged by authorities to keep distance, to follow hygienic rules. The refugees in camps lived on tighter spaces with shared sanitaries and communal feeding. So what we see is that we have limited resources of protection in terms of hygienic resources and space. Like when we take a little deeper look, we see that the hygienic situation is based on there's partly not enough soap or not enough masks, not enough disinfection. The slots for eating are smaller. Many people are in small rooms living together, partly without windows to the outside, but windows to the inside. They have to share the toilets, they have to share the washing rooms and the kitchens. So people live together in a situation which is very small. They have very small room. So the migrants depending on their residence permit status, have limited access as well to the public health system, which is one further aspect of the question who can protect himself and who has the right to security. And as well, what we see is that when we had the situation of quarantine in many camps, we see that there was a lockdown like for hundreds of people by having just 1 or 2 corona cases within the camps. And this was a really, or is a really difficult situation for the inhabitants. They put whole camps under quarantine so that hundreds of people couldn't go out or can't go out. Children as well should stay at home, can't go to school, etc. So as well, this situation has influence on the high rate of COVID because like inhabitants reported, that inside the camps, the positively and negatively tested persons had to continue to share rooms sometimes. And we see that if you have those lockdown situations, more and more people get sick within the camps. So we see that the right to health and integrity, to physical integrity, and the right to residence without interference to health is hardly cut for many of the inhabitants. There is no guarantee that of residence without interference to health, although this should be by law. And as well, what we see is that the right or the non-existing right to physical integrity and protection in this situation of Corona shows an internal frontier to whom decrees count and to whom not. So we have more fields where we can observe reduction of rights. One is around the theme of information, and we can observe that people did not get informed about their situation or the situation which led people or the situation of the families in other countries. So especially those with families in countries with a very high COVID rate, like Iranian refugees, got very worried about their own situation inside the camps. And confronted with a hard lockdown of the camps, people didn't know how to secure their lives. As well, the limited information about the virus and how to protect had an influence on the situation. Furthermore, we see that there are brutal police interventions in the name of measures of quarantine that were made that brought up a very special atmosphere and situation because people didn't know what was happening. They were afraid about mass deportations and didn't know how they could interpret the police behavior. So this lack of information in this situation, was a very very hard cut into the rights of refugees. And when we ask what does social distancing mean in situation for bodies under life whose life is under state control in camps and who don't have private spheres, we see as well that people have with less contact to other people now are even more limited in their daily life. And as well, we see an impact on social work in the camps because we had no organizations like counseling organizations who could enter into the camp. And we had as well the situation that social workers or within the discipline working other people, like people who did run kindergartens in the camps, couldn't go along with it because it was forbidden by the authorities to enter. So there were very few, or still there are in many camps, very few social workers within the camps who can counsel, who can inform people, who can run those services, like services for children. And we see that those social workers who are inside now have a very as well a very limited opportunities to work inside those inside the camps. So we have the right on information, and as well the right to get counseled, which is limited for refugees. And around that, we saw as well that the right to freedom of expression by demonstration was cut. There were protests which were partly forbidden, protests inside and outside camps, which were partly forbidden. Refugees themselves had the impression that it gets harder, that the situation gets harder, and that they even can't find open ears outside the camps for their situation. So we found protests like hunger strikes. And it was outside the police and inside security services teams who partly worked with methods of brutality against refugees and their protests. So what we see as well is that the try to a community building and solidarity within the camps of the inhabitants were tried to destruct it. We have one more, or I have one more example of rights.
Suzanne,
Yeah.
5 dakikanız kaldı.
You have 5 minutes.
I have 5 minutes. Okay, yeah, that's fine. That's fine. It's the example of the right to family life, and we see that the right to have a family reunion was abolished, and this is one of the politics combined with Corona that hit refugees very hard. By restricting the entry requirement, this matches refugees and their family members in other countries who now can't be reunited with their families. So even if they had a visa, they couldn't entry to Germany. And so a family reunion for the last over the last months couldn't happen. Because non-EU citizens need an urgent reason for entry, and it was not seen as an urgent reason, the family reunion. So we see that as well a basic right, like the right to family and family life, was undermined within this situation. So to have a short, perhaps some kind of a short conclusion after some impressions I gave about the situation, is that we can see that Corona and the measures around Corona got part of intensifying institutional racism. We see camps as spaces of vulnerability, as spaces of limitations to rights. And we see as well an ordered absence of social work, social workers who should not work there, as well the whole volunteer community who should not go into the camps. The surrounding communities of counseling, free counseling, like the refugees councils and so on, could not go into the camp. And so we see more control of the state, but less control about what the state is doing. And as well, we see a strong shift to social work as, like Albert Scheer called it, the administration of exclusion, more than being part of inclusion, being a part of administration of exclusion. So as well, when we think about the solidarity and theme that, or the social work as a human rights-based profession, the right to have rights was hit once more by the pandemic measures, and we see that especially in the community of refugees. So I think today we have to find new ways, like creating collective spaces and broaden the networks, especially within the pandemic situation. Or this makes it very clear. I mean, the tendencies are not new, but they are really getting stronger within the situation. And we need spaces to thematize blocking racist structures and to defend people's rights, and as well spaces of empowerment for social workers. So thank you. Looking forward for the next presentations and the discussion.
Evet, çok teşekkürler Suzanne.
We thank you very much, Suzanne.
Bir önceki panelde nasıl
Now,
olmalı
in the previous panel,
diye konuşurken şimdi
we talked about what social work should do, how it should change. And now we're hearing what actually did happen during the pandemic. And Susanna's presentation, therefore, was very concerning due to its, content. And now, before I give the floor to the next speaker, I have an announcement to make. This is broadcast live on the internet, and those of you who are following us on the internet, there is a ask a question button there. And if you have a question, then you can type in your questions in that box and we'll be able to see your questions. And do not delay your questions. If you have questions for the first two speakers, please type them already so we can get them timely. Now, third speaker, I would like to give the floor to Professor Juliane Karakayalı. She's going to talk about the conflict around the pandemic, the measures against the pandemic in the refugee camps in Germany. The floor is yours, Professor.
Thank you. Thank you for the invitation, and thank you for organizing this conference. I mean, it's really good to be together here, although it's only online, but it's better than to stay in the isolation in this pandemic situation. I feel a bit sorry because obviously Susanne Spindler and I prepared the exact same speech. So I'm a bit sorry that you might hear now the same speech again. I mean, it's not completely the same, but yeah, so I hope that you don't get bored, or maybe it's a good thing because then you can process the informations even better listening to them for the second time. I have to apologize because I don't have a PowerPoint to share. My computer went partly on strike this morning, so I will try to be as organized in my speech as I would be if I had a PowerPoint. But that means that I have to stick to my notes that I have here, so I can't always look directly into the camera. I will talk about the situation in refugee camps in Germany under the pandemic, and I will briefly outline first the violation of human rights in refugee camps in general. Second, how Corona affected the life in these camps. Third, what refugee organizations and health organizations are demanding in this situation. And fourth, how protests against the precarious conditions were answered violently by the police. Unfortunately, I can't present best practice examples or helpful policies because currently there seem to be none in Germany. I apologize also for that. First of all, I will briefly outline the situation in refugee camps in general. As Germany has a federal political system, there's a huge variety of politics of refugee hosting in the country. There's no overall documentation about the situation in refugee camps, but it is estimated that in 2019, only 45% of all refugees were hosted in decentralized accommodations like flats. That means that 55% have to stay in refugee camps while they undergo the asylum procedure. And due to housing shortages in many parts of Germany, many refugees have even then to stay in these camps after they receive the asylum status. Refugee camps vary in size. Small camps host about 30 people, but there are also huge camps where up to 1,000 or even 1,500 people live. Although there is no official documentation, NGOs estimate that currently about 330,000 refugees have to stay in camps in Germany. These camps are violating human rights in many ways, even when there's no pandemic. And within the professional associations of social workers, it is widely doubted that human rights mandated social work is even possible in these camps. So according to the Institute for Human Rights in Germany, we can state that the main problems are that people are forced to share rooms with strangers. There's no private sphere. Kitchen, dining rooms, bathrooms have to be shared with a lot of people. Like, for example, as we already heard, one toilet for 10 people or 2 stoves for 20 people or stuff like that. So therefore, there is a permanent noisy and restless atmosphere in these camps. The food is often bad and not sufficient and not adjusted to cultural habits. There's no easy accessible psychosocial or health support, and women, children, and other vulnerable groups face often sexual and physical violence in these camps. Living in a refugee camp means to be separated from society, especially when they are located in the countryside. Refugee camps at the countryside make it difficult to meet a lawyer, to engage in support groups, or to get medical support due to a lack of public transport. Often security guards and social workers are the only frequent contact to society outside the camp, and both groups have almost unlimited authority because they hardly get controlled by any institution. There are frequently reports on security guards that used violence against refugees in the camps or who acted racist or sexist or were part of right-wing movements. As there is a lack of social work within these camps, one social worker is often responsible for too many people to provide them with the support that is needed, especially because social workers often have to fulfill tasks that have nothing to do with social work, like organizing the daily meals or stuff like that. The position of the social worker opens up opportunities for an abuse of power, especially when resources are insufficient and social workers feel under pressure. So as we can see, the whole structure of refugee camps in Germany is against everything that social work stands for. First of all, supporting people in living a self-determined life. And therefore, social workers associations criticize this accommodation format for many years now. Now I will come to the second point, how the pandemic situation affects the refugee camps. We already heard a few of the points that I will make now. The pandemic situation made things even worse and reinforces all the mentioned problems. There is no official data about how the pandemic affects refugee camps or the number of infection in refugee camps. The Mediendienst Integration, a news agency in Germany, tried to collect data from the federal governments without success because some federal governments do not document the cases at all. Some others only document current infections, so we don't really know anything about numbers of infections in refugee camps. The only number that we have is that estimated 3,000 infections happened only in Bavaria in refugee camps there. Bavaria is only one of 16 federal states, so we can maybe estimate what the other numbers might be. So in the following, I refer to reports from NGOs like the Kommen Zusammen or refugee councils and media reports. A study by Bielefeld University shows how fast the virus spreads in refugee camps due to too many people sharing too small space. Due to this study, the infection risk in refugee camps is as high as it is on cruise ships. And traveling by cruise ships is, as we all know, forbidden during the pandemic, but living in refugee camps is not. Why is the infection risk so high? As I already mentioned, first of all, it is impossible to keep distance in refugee camps. Many people share bedrooms, bathrooms, dining rooms, and kitchens. Hallways are narrow, so if one person gets infected, the virus will spread fast. And in the beginning of the pandemic, as Susanne already mentioned, that meant that the whole camp was put into quarantine when infections happened. In one camp in Halberstadt in Brandenburg, for example, 840 people had to stay in quarantine for 39 days. In Geldersheim in Bavaria, 600 people had to stay in quarantine for unbelievable 8 weeks. So these are really, really long times. And quarantine is a special hardness to people who have to stay in refugee camps because it means to be stuck in these camps. You can't see your lawyer. You can't buy food to make the poor camp catering more bearable. You can't buy everyday supplies like, for example, soap or tampons. It means that people have to stay 14 days in their narrow rooms that they have to share with strangers. People who have to stay in container camps are stuck there for 14 days, also during hot summer days with about 50 degrees inside these tin containers. Children are not allowed to go to school, and it means that it is accepted that the virus spreads throughout the refugee camp, while in the rest of society, especially that is tried to prevent. In some federal countries, infected refugees are now brought to quarantine camps, or special areas of the camp are declared as quarantine areas to avoid a quarantine for all people living in the camp. But this is not everywhere the practice. So it really depends on where the camp is located, if these practices are done or not. But even besides quarantine, there are a lot of difficulties. During the lockdown, many children, as we already heard, and youth could hardly learn for school, as there are often not enough computers in the camps. We also talked to teachers how they try to provide the children that live in refugee camps with material so that they can learn. And many teachers really had no idea how to do that. Some of them were like going by bike to the camps to bring material like paper and pens and everything to the camps, so that the children got a chance to learn something. But it was very difficult because you really need some kind of advice when nobody around you talks German. How shall the children learn German without any kind of contact, because there's no access to computers, for example. Refugees also have limited access to medical infrastructure during the pandemic. As the social workers are so powerful in these camps, they are often the only ones to decide if somebody gets medical help. Often refugees have to fight to get tested. They have to fight to get written test results, to get clinical thermometers, or to be brought to hospital, even when they have corona symptoms like high fever or cough. And during the national lockdown in spring, some camps were cut off public transport. So that meant that there was no opportunity to get out of the camps to see other people, NGOs, lawyers, and so on. Voluntary workers and NGOs had no access to the camps during the lockdown, and social workers very often had to fulfill their task digital or via telephone, or to find quite innovative forms of keeping in touch with the clients in the camps. Now I will talk about my third point, and I will briefly outline what health organizations, refugee organizations, and social workers are demanding. First of all, the National Public Health Institute, the Robert Koch Institute, developed a protection concept for refugees, for refugee camps. And this institute recommends as follows. First of all, multilingual informations, oral and written and explained by translators about the virus, about the progression of the disease, transmission paths, and so on. Second, and this is, I think, the most important recommendation. Second, they recommend that people that belong to risk groups have to be identified and to have to be brought out of these camps, because it's impossible to really protect them from the virus when they still live in the camps. So this means that there's the recommendation that risk groups have to be brought to flats so that they are not in this higher risk in the refugee camps anymore. Another recommendation is that camps must provide the opportunity to keep distance. Best case in providing single rooms, or if this is not possible, the inhabitants of the often huge camps have to be split in small and stable groups so that infections can be better prevented. And camps must provide hygiene products like soap, disinfection material, and masks. And there has to be access to psychosocial support and health consultations at all times for everybody in these camps. So this protection concept is widely ignored. It was released already in May, but nothing happened since then. Social workers who are organized in the Professional Association of Social Workers demanded additionally that the working conditions of social workers have to be monitored, and that there has to be a realistic redistribution of tasks, because in this pandemic situation they are not able to work in a normal way. And refugee organizations claim for the liquidization of the camp system that is the root of the crisis, and that does not seem to be reformable. And in many refugee camps, refugees protested against the pandemic policies, some in a collective way, as we already heard, also with hunger strikes, some individually. And I come now to my fourth point. When we look how the reaction was or is on refugee protests, then we can see that instead of reliable protection concepts, often the police is called in the context of corona outbreaks in refugee camps. For example, police is called when refugees protest, when they are forced to move into a crowded camp, or when they protest against the bad food in the camps, or that there's not enough food, or that they do not get any informations. So in some camps, people protested, and immediately the police was called. In many places, the police controlled the quarantine in refugee camps. That means that police cars patrol out of in front of the refugee camps to make sure that nobody leaves the camp. And we can see that the picture of police in the context of corona and refugee camps contributes to the racist public discourse on refugees as a threat to society. This is, I think, one of a really big problem that is not addressed by political authorities until now. So to conclude, although refugees protested visibly against the poor conditions, and although the highly dangerous situation in refugee camps is covered by media, there are lots of reports about situations in refugee camps, nothing substantial changed so far. The only way out of these dangerous refugee camp situations seems to be to start individual actions at court. So in some cities, refugees took legal actions against their accommodation in refugee camps, and some of them succeeded. They were allowed to move out. But in Germany, the only opportunity is to go individually to court. And that means that only a few people managed to get out of the refugee camps. So this can't be the solution. I think this is obvious. It can't be a solution that individuals have to claim for their rights at court, but a bigger like political change we can't see at the moment. So thank you.
Çok teşekkürler Juliane.
Thank you so much.
Bizim sunumlarımız birbirine çok benziyor
Our
demiştiniz.
presentations, you said, were, I mean, your presentations were very similar, but this I don't think is a problem because there were different emphases. And this was really informative. I mean, being able to listen to both of your presentations back to back was informative. Thank you to both of you. Now, Turkey actually has the largest population of refugees in the world currently. We have about 4 million, perhaps more than 4 million refugees in Turkey, and close to 1 million unregistered, i.e. informal refugees in Turkey. Syrian refugees have a status of temporary protection. So we're talking about 3.6 million Syrians alone. And because of this status they have access to basic health care services. And what also needs to be said is in Turkey, a very small portion of refugees live in refugee camps. Most of them are subject to a resettlement regime. But there are readmission centers for irregular migrants. That is where they are kept before they are deported and sent back to their countries. The conditions in those centers, we have always known, have been bad. Although they have access to basic healthcare services on paper, during the pandemic, the refugees had challenges in having access to those health services and to online education services at the same time. This is something we know from recent pieces of research conducted in recent months. I just wanted to explain this before I gave the floor to our last speaker. Our last speaker is Mr. Kemal Vural Tarlan. He's our last speaker. And within the refugee communities in Turkey, the most vulnerable subgroups will be the subject of his speech, namely Dom and Abdal communities within the refugees, and the floor is yours. Hello everyone, once again. First of all, I would like to thank you for your invitation and for organizing this meeting. Now, as you mentioned, I'm sorry, the speaker's voice is cut off. Now, I work with refugees, but for about the last 20 years now, we mainly work more specifically with DOM groups in the Middle East. And since 2011, we have received groups of DOM people moving from Syria to neighboring countries, to Turkey and other neighboring countries. There is the DOM community, and there is another subgroup, which is the Abdal group community. And rights-based defense or an activism is what we try to do. I don't have a presentation, but I have main headings. My first heading is the following. Now, what did the situation of those communities in the Middle East look like before the pandemic? And how about the current situation they are in? And then I will talk about what they have been going through during the pandemic. But mostly after the after the pandemic broke out, what kind of experiences have we observed and seen on the field, and what's happening with the families? And lastly, I'll talk about the access of these communities to social services and the kind of obstacles they encounter. And I'll also try to come up with some suggestions. During the initial days of the pandemic, in April, just like in other countries, the government in Turkey declared curfew, and we looked at Turkey, Jordan, and Lebanon, and we had interviews immediately, and we made a call on governments and also on international organizations regarding Dom and Abdal communities, warning them that these subgroups are under specific risks during the pandemic. That's what I will be talking about. Now, Dom people. Now, more or less, you probably know about this community. They are one of the three main gypsy communities in the world. They live in the Middle East. And in almost all countries of the Middle East, you find Dom groups. And the estimate is that something between 3 to 5 million in total are dispersed among different countries in the Middle East, as far as we know. And the Abdal group, within this group, is a subgroup. Most of them live in Turkey, but there are some groups also live in some other Middle Eastern countries and in Balkan countries as well. In my speech today, I will mainly focus on those groups which have migrated from Syria to Turkey, both Dom and Abdal groups. These communities today also have they still have a nomadic group. They are called peripatetic groups, which means a nomadic group of artisans. And their artisanship skills have lost their validity today, but today, even if they move into a settled life, they are hurt by discrimination or isolation and exclusion, and they still turn into nomadic people and move to other places. In the Middle East, the situation it changes. I mean, meaning for the last 30 years now, there are conflicts in the Middle East. So particularly for these two communities, this has created specific risks. When I say 30 years, I'm talking about the process which started with occupation of Iraq by the US and the conflicts following suit. In this region, although they coexist with other peoples, especially as a result of such turmoil and conflicts, they are not wanted. They are seen as unwanted people by radical groups and governments. Although they are not parts to conflicts per se, these communities are hurt badly because some radical Islamist groups believe that these communities are not good enough Muslims. And governments who, when they come to rule, they don't want gypsies in their community. And again, I lost the speaker's sound. His sound sometimes gets interrupted. So for the most part, they feel obligated to become nomads again, or they try to be invisible in big cities. With the civil war in Syria, we have received something like 40 to 50,000 people moving to Turkey, Doms and Abdals, refugees namely. And for the most part, they started coming, Turkmens, Kurds, and Arabs, the other groups of refugees did not accept them into their own refugee camps. They said they didn't want to live in the same refugee camps with these gypsies. So the Dom and Abdal people are distributed among different big cities in Turkey. And in Turkey, just like other groups, they work as seasonal agricultural workers, or they collect garbage and scrap, and they try to make a living with such precarious work. And they, because of this lifestyle, they have a hard time. The refugees in Turkey, as you mentioned already, we're talking about 3.6 million Syrian refugees alone in Turkey, which enjoy the status of temporary protection. And generally, these groups of refugees are perceived as a homogeneous group, but socioeconomically, there are different types of groups within the entire group of refugees. Within this, Dom and Abdal people are the most disadvantaged groups because they have been marginalized as groups for the most part, and they have the highest level of vulnerability. During the pandemic, just like in other countries, in Turkey also, we haven't been able to gather data from governments, actually. I mean, the level of spread of the pandemic among the refugee community in Turkey is something we don't have a data on. How many people died from among the refugees precisely, or how about the total number of cases? I mean, we don't have such data per se. And it's just that we, as NGOs who actually work on the field, we just observe reality on the field, and that's how we try to gather data or information. And also, you would know from other parts of the world, there are neighborhoods of gypsies, Roma people, I'm sorry, where Dom and Abdal people live. And the city dwellers normally know which neighborhoods those are. Our Ministry of Health has an application, a mobile phone application. When you look at those, I mean, that's an application showing you the density of cases of pandemic. It's a map with different colors. And when you look at those specific neighborhoods, you see the color red. You see more dense red colors in those specific neighborhoods where they live. That's one source of information for us. And other than that, as I said, the other pieces of information is gathered through personal encounters when we work actually on the field, and the kinds of incidents and events that we personally observe. COVID-19 pandemic for the refugee communities, as has already been stated by the previous speakers, means a lot of risks. But within these refugee groups, there are comparatively more disadvantaged and vulnerable groups. For them, the risk is multiplied, as you already know. In our case, particularly Dom people, on the one hand, they are subject to discrimination because of being refugees in our country, but at the same time, by mainstream refugees, they again are subject to yet another discrimination because of being gypsies, and they become more and more vulnerable in time. Moreover, during this pandemic, the neighborhoods that these groups live, I mean, where Dom and Abdal people live, when you look at these neighborhoods in Turkey, you see that they have bad sanitation conditions and not proper access to water, and you have, in many cases, more than one family living in the same house, which causes an extra risk because of pandemic, because of extra contact. And again, in these neighborhoods where Dom and Abdal people live, and in those particular cities, in many cases, we see that people raise concerns like, oh, these people are bad, they are dirty, filthy gypsies, they are the root cause of the pandemic, they brought over the contagion to us, and people don't employ these people. This is one observation we have. And as a result, this becomes the main reason as to why these people cannot leave their neighborhoods, and then poverty gets deeper. Our NGO, named Kırkayak Cultural Center, what we have done is, when the pandemic first broke out, in a short period of time, we closed down our offices, and we took a decision of working from home. But then there was a woman who called me up. She said, The government, by the way, 1 day ago had announced a four-day curfew. And she said, okay, the government tells me not to leave my household for 4 days, but at the moment I have 4 children in my household. We are in total 7 people and we don't have any food to eat at all. If we don't leave the house for 4 days in a row, we will starve here, she said on the phone. So we took a decision as an NGO, and we took measures and continued to go to the field, especially to make sure that people were served and they could have access to food. As far as possible, we tried to support these families. And at the same time, this period was actually normally was a period where you would expect to have the strongest level of solidarity with groups, particularly with refugee groups. But there was this family we encountered. They said, we don't want aid from you, but this is seen as a gypsy neighborhood and no one else comes in. You are the only ones who call on, who visit us in this neighborhood. The fact alone that you come over and ask us how we're doing is in and itself meaningful to us, they said. Kırkayak Cultural Center, actually, I mean, we are not a humanitarian aid organization per se, but during the pandemic, during this particular period, the services provided by the government and provided by other humanitarian aid organizations were important, and we facilitated the aid they provided, and we facilitated reaching of that aid to groups, including refugee groups. So we used as intermediaries, and we acted as an NGO on the field for that purpose. Now, these risks are not only about life and death that have to do with pandemic. There is poverty, there is unemployment, which become more and more widespread in these communities. This happened during this pandemic period. Poverty among these groups, among these communities, has been perpetuated because our groups generally work in precarious work, or they engage in collecting of garbage, waste, or scrap, and they work as seasonal agricultural workers. So doing those works have been impossible because they haven't been able to go out. So they weren't able to do even precarious work. As a result, families became poorer. And this wasn't the case in Turkey alone. As you know, Turkey is also going through an economic crisis. This holds true for other Middle Eastern countries, including Syrians, which means a lot of risk. And when it comes to health, Syrian refugees in our country, yes, they do have access to basic healthcare systems. The procedure is there, yes, but
I lost the sound of the speaker. The speaker gets disconnected sometimes. We're awfully sorry. Well, actually, there are people who are not yet diagnosed with COVID-19 infection. We have an area where we have tents housing the refugees. Although they were not diagnosed with COVID-19, 3 young men died of heart attacks in that tent territory. Kemal Bey, can you please sum up in a few minutes? I'm sorry to interrupt. On the other hand, regarding education, there are also certain risks which are similar for all the countries. About 95% of Dom adult children have no access to school, and that 5% who had some access to education are now experiencing problems accessing education online, because online education has become online during the pandemic in Turkey. Well, actually, in the post-COVID period, there may be a few things that can be done for these communities, especially for refugees and disadvantaged communities in Turkey. We have a large number of humanitarian NGOs and humanitarian international organizations working with them, but the services of both the NGOs and international organizations came almost to a halt because of the COVID-19 crisis. We have to rethink how these NGOs and organizations should act in times of crisis. We should have been out there. We should have been ready to help. We should have been there with emergency response. We thought we could, but all of a sudden, we just locked ourselves in our homes and started working from our homes instead of going out there to help people. And I would say that especially international humanitarian aid organizations that work intensively in Turkey should rediscuss and rethink their positions in responding the crisis. Thank you. Thank you very much. Thank you very much, Mr. Tarlan. Well, those were very important points that you brought out in your presentation, especially in the last section. Now I would like to proceed with questions. Nabila Al-Basal, of course, there is an 8-hour difference between our time zone and her time zone. And thank you very much, Nabila, for joining us, although it's very early for you. She has another meeting. She has to leave early. So I'd like to ask the 2 questions for her first. Question 1 is as follows. In Turkey, during the pandemic, many services came to a halt. For example, organizations working in chronic mental health offered their services only over telephone. And this had a negative impact. What kind of preventive measures did you take in the US when you work in the field? How did you protect yourself and other field workers against the COVID-19 infections in the field? And we have one more question for you. In the HEAL research, which other scientific disciplines collaborated with you? Can you please repeat them and list them for us? Thank you.
Okay, I'll start with the last question, and I may ask you to repeat the first question because I didn't hear it. But the first question about the disciplines is the easiest one. Social workers are the lead investigators on this study. It's Columbia University School of Social Work. And the other disciplines, we have addiction scientists who do work on addiction research. We have system scientists. We have modelers in terms of prediction and modeling. And we have mental health and psychiatrists with us, as well as we have biostatisticians and statisticians with us and methodologists around research. So these disciplines came together, wrote the application, and continue to work together to implement the research. So that's the last question. Can you repeat the first question if you don't mind?
Okay. Okay. First question.
Yes.
During the pandemic, many services came to a halt in Turkey. For example, the organizations working in chronic mental health offered their services over the telephone only. This had a negative impact on the disease. In the US, you could continue the HEAL during the pandemic. What kind of preventive measures did you take to protect yourself and other field workers against the infection?
That's really a good question. First, let me say that the Healing Community Study that works through coalitions continue to meet on Zoom. and continue to engage the community through Zoom. But one important really strategy used in the US in general and specific in New York State is everything turned to be delivering services, health, mental health through Zoom and through telemedicine, telehealth. And the coalitions made a decision really to work very hard to ensure that people at home have phone to call for services, or they have computers at home to be able to continue the services. So many agencies, health, mental health, addiction services, identify the needs of the community, especially the clients, in order to make sure they can access the new technology to be receiving services. Everything turned to be really on Zoom for the clients. And I have to tell you, many of the clients loved this approach and were engaged in treatment. In terms of the protecting our researchers and coalitions, we made sure that they have access to all the protective measures that they need in order to continue their work.
Okay, thank you very much, Nabila. Thank you for joining us again. You can leave anytime because you're otherwise engaged. So now there is one question to Ms. Spindler. During the pandemic, how can the local governments play a role in the prevention of rights violations? So what should the role of the local governments be in preventing a violation of rights? One more question for you again. You mainly talked about refugees in the camps. How about refugees living outside of the camps? How is their situation? Now, you have the floor.
The first question about the local government is really interesting because I think that a local government has possibilities to not to violate the rights. It's one thing on housing. Like there are many there are many demands on solving the problem of the camps by giving them up, giving people accommodation outside, like in hotels or in other safer spaces. As well, the question who can enter a camp is not like it's not like all over the country it's the same, or even in the same states it's the same. So it hardly depend, or it's mainly depends on the local governments, how they reflect the situation and how they act within, and how they tell, for instance, social workers or volunteers if they can enter or not, what they can do or not. So we have very in different cities we have very different differing situations on how the rights of the refugees, the small rights that are left, can be protected by counseling and by social work. And I think that local government can be supportive, but as well can be suppressive in that way. The second question was, sorry, I forgot. Could you repeat it, please?
Let me repeat the second question. How about the refugees who live outside of the camps?
Yeah. I think this is a very different. The situations differ a lot about. It's about the status. So, which legal status do you have? If you have a status like a recognized refugee, then your situation is normally much better than if your status is not already cleared, or if you have like a status like the Duldung, which is a non-status, which is just the stop of deportation. So we have very different, different situations outside the camps. I mean, what's going on, we didn't talk about, or we talked about in the other panel, I think it was about racist stereotypes, about the question who spreads the virus and so on. And I think this racist behavior is even harder for refugees. But I think I cannot make like one. I can't say that the situation is comparable outside the camps to the different refugees. It depends on where they live and on the status.
Thank you very much. Now, there are a few questions for Juliana Karakayalı. One question: do you think that the social services in Germany are short of being adequate in the pre and post-pandemic period? Are there any social service areas that are less than adequate in Germany? That is the main question. And again, second question for you: social workers who work in the camps, what are the suggestions or recommendations of the Social Workers Association for those social workers who work in the camp? You only mentioned about a redistribution of their responsibilities, but can you please explain what you mean by this? There is one more question about Germany and social work in Germany. In the pandemic, the social services are getting redefined and the conditions are changing. Are the social workers getting the training to adapt to these changing conditions?
Okay, thank you. So many questions. Yeah, to answer the first one, if social services are inadequate, I would say when it comes to refugee camps, they are always inadequate. I mean, there's a lack of everything when it comes to what kind of social work is possible in refugee camps. I would say there's almost nothing possible. It's really a structural and institutional problem that you can't solve. I would say I would really say, as long as there are refugee camps, there will never be an adequate kind of social service there, because the whole idea of these camps in bringing people there together, giving them only very, very limited possibilities to live their lives in an individual way, to give them not enough resources for example, such simple things like being able to sleep during the night, because it's so loud and so noisy there, and people are there stuck together with so many problems and so many, I don't know, insecurities, and nobody's there to really care for them. There's no access to, as I said, to, for example, psychological consultations. So I would say, when it comes to the refugee camps, it's always inadequate. It's a lack of resources, a lack of social workers working there, a lack of everything. For the second, the second questions, maybe I have to answer it in a similar way. The problem is that there are not so many recommendations now during the pandemic from the Association of Social Workers, because it's a very a complicated field of social work anyway. So the discussions around social work in camps, even in the last years, even without the pandemic, were always around the question if is real social work like this, the social workers who refer to the mandate of human rights is possible at all in these camps. So, for example, in the 90s, there was always a debate if it's tolerable to work in a refugee camp, but there were not so many then, you know, because the migration wasn't so, numbers of migration weren't so high in the 90s. So now it became a quite normal field of social work again, but it's absolutely controversial, discussed. And so one of the uh, main recommendations always is that there need to be another kind of like professional understanding of what social work is. Like, for example, I don't know how it is in Turkey, for example, but I think in other parts of the world, it's more normal and it's standard that social work is connected to an understanding of social work as a human rights profession. In Germany, it's not so strong, one must say. I mean, there's this idea that this should be the basis of social work, but there's nothing like a real ethos or something that you can sign when you finished your social work studies, you know, so that you really can say, okay, this is my obligation now to be in charge of acting according to the human rights. So as far as I know, there are no real recommendations in terms of you should do this or that. It's always these overall demandings or claims that are made that the working conditions have to be better, because then the treatment of the people that have to stay in these refugee camps have to be better. Concerning the third question, I'm not really sure if I understood that right. If there are new, like, if the pandemic also changes the professions, or I don't know, maybe you can say it again, the third question.
This is the question. In the conditions of the pandemic, did you also change the training of social workers to adapt to the changing conditions?
Yeah, this is an interesting question. Yeah, this is really an interesting question. I'm not sure if I can understand, I can answer that. I mean, I can just talk about, for example, our University for Applied Sciences. We did never ever talk about digital ways of offering social work, for example, and this changes now dramatically. So I would say maybe it's in other universities as well, that the digital opportunities of providing social work are more and more discussed, and they are invented more and more like courses and seminars at my university to address that. I would say in other areas of social work, there's no other opportunity than to change the normal ways or the established ways of providing social work, because the need of social distancing or physical distancing has changes everything. So I would say we already can see that at the university, but we also can see that in many fields of social work, that people just have to invent new practices. Yeah.
Thank you. There are some questions to Kemal, but still, since Nabila is still here, there's one more question to Nabila. So I would like to ask that question to her. In the US, in the US, do we have anything similar to the healing study, which is carried out in a community-based manner. Can you give us some examples of similar studies?
This is really a great question, but I have to say the Healing Community Study is the largest funded research by the US government on community-based research. Overall, it's very hard to get funding for community-based research, but because of the overdose deaths increasing tremendously and so many people, 500,000 people died from 1999 to now, the government of the US decided to give $350 million to advance the science of community-based research. Although there are a small randomized clinical trials where the community is involved, but small studies with community, like in the area of mental health, in the area of substance abuse, but not as large one where really the opportunity to advance the science of community-based can be done through this kind of model. But it's really important to highlight that the Healing Community Study also a study that is being implemented in 4 states, 4 states with different political contexts, 4 states with different policies, 4 states with different infrastructure, and we include rural and non-rural areas. So there is no study as the Healing Community research that can answer these really huge research questions, as well as to address the context and the policies and involve the government in this process. So to answer your question, there are small studies, but not such as the Healing Community Study. And we believe that the Healing Community Study is going to be used not only for addressing the opioid crisis, but can be used for COVID and other pandemic and epidemic, because the voices of the communities are involved and because we have a strong multidisciplinary approach to the whole study.
Thank you very much for your answer. Thank you. That was very informative. Now, I have questions here now for Kemal. Now, these refugees, do they have any access to health services in other medical problems outside of COVID problems? And that's the first question. The second question is, Dom and Abdal refugees, does the Turkish government have special policies for these refugees? And if not, what kind of special policies could be suggested? I have a question too, my personal question, Kemal. Now, you told us that in Gaziantep, these refugees, these groups specifically, live in certain areas in Gaziantep. Are they also discriminated by the mainstream Syrian refugees? That's my question. I will start with your first question first, if you allow me. Now, in Turkey, oh, I don't know if this is my connection, but I can't hear the speaker. I don't think it's my connection. Now, he's back. Well, they get some services at the family health center, and also with the support of UN and the EU, there are migrant health services institutions, and they can get access to health services there as well. But the main problem here in this community is discrimination. There is the family health center. They serve other Syrian refugees. However, when these specific groups go, they're turned away. Even in the secondary health services system, there are certain limitations. These communities need to have, all of them need to have access to emergency medical services, and even there are some problems with this specific community. Last year, a pregnant woman who was in labor went to the hospital and she was turned away, and we lost the mom and the baby. So there are very restricted services, and even within those restricted services, due to discrimination there, access to the restricted services is also restricted. So this was the case before the pandemic, and this increased dramatically. Now, the Turkish government, whether they have a specific policy concerning Dom and Abdal refugees. Well, the Syrian refugees in Turkey are under the protection of the government. They're under temporary protection. There is no social ethnic discrimination there at all. The communities that I'm talking about are also included within that framework, but they are discriminated against, they are heavily marginalized, and therefore these communities have huge trouble accessing services offered by the government or by NGOs, by the NGOs. The personnel, the staff working for NGOs, they have prejudices against the Roma people. When they apply to a government office, they are turned away because they belong to the Roma people and they cannot enjoy the services otherwise provided to other refugees, other Syrian refugees. Now, you had a question for me. I forgot your question though. Could you repeat that question, please? So I was wondering whether the Syrians themselves are also discriminative against the Dom and Abdal refugees. Well, yes. In the Middle Eastern countries, you know that there's this prejudice against the Roma people. In the West, there are many institutions standing for the rights of the Roma. And they have a long history too. They are very well established. However, when you come over here to the Middle Eastern countries, you see that there is a huge prejudice against the Roma. People have very strong sentiments against them. And therefore, the other Syrian refugees always accuse the Dom and Abdal, the gypsies, the Roma people, of begging in the streets and other such activities. No, these are not Syrians. That's what they say. Automatically, they say, these are not Syrians. Even when they were in Syria, these were the beggars. These were the thieves. These were the, muggers, and so on and so forth. So they also accuse and stigmatize, and they have hate discourse about these refugees. The other Syrian refugees discriminate against the Dom and Abdal as well, I should say. Okay, thank you very much. Thank you very much for your answers. I cannot see any more questions, which I think is a perfect timing for us right now, because this really brings us to the end of this panel and the end of the conference. I thank very much the four speakers who were panelists, and I ask for all the questions, and I thank everyone who asked questions and the interpreters. This was really a very interesting panel, don't you think? I mean, we had four speakers touching upon four topics, and it was very interesting to follow, and I'm sure we will remember this panel really, because this led to thinking. I'm very happy about this panel. So I thank all of you for all your contributions. Now, distinguished participants, this will be the end of the first day, And tomorrow at 11, we will reconvene with the fourth session. Okay, so good evening, everyone, and thank you very much.